Welcome to this Beyond Zero e-learning module on neonatal art. Please see the link in the notes section to accompanying articles and tools and other e-learning modules published by Beyond Zero. In South Africa, 29% of babies are born to mothers that are HIV positive. Due to the rollout of an extensive and comprehensive ARV program, the transmission of mother to baby in 2016 was standing at 1.5%. So fewer and fewer children are infected with HIV, which is great news, but we are still aiming for zero transmission. But for those children that do get infected, we want to diagnose them as early as possible. To ensure that we find all HIV positive babies early, we now do a birth PCR at birth for all exposed HIV babies, and results are often available within a week. The PCR will be repeated at 10 weeks, 16 to 18 weeks for babies that had been on a Nevirapine for 12 weeks, and of course can be done at any time for a baby with clinical symptoms of HIV. Early testing means that doctors and nurses are now seeing children diagnosed at birth with HIV. But how do we best manage a baby with a positive birth PCR? The national ARV guidelines tell us clearly that all babies less than 1 year of age must be started on ARVs within a week of diagnosis. We also know that 50% of babies with HIV will die by the age of 2 without ARVs. But we cannot use the normal first-line regimen for children of ABACAVIR, 3TC and LOPINAVir, ritonavir in neonates or babies weighing less than 3 kilograms. We have very little safety and efficacy data on ART in premature or small babies, which severely limits our options. The challenge is even bigger with premature or low birth weight neonates. This is why the ARV drug dosing chart of 2013 recommends that you consult an expert in all babies less than 28 days of age or less than 3 kilograms. Dr. James Nuttall from Red Cross Hospital published an excellent overview on ARV therapy during the neonatal period, and this has formed the basis for current recommendations on neonatal ARV management. Let us look at our top 5 ARVs normally used in children. This article, as well as the neonatal protocol, is part of this e-learning pack. Although ABACAVIR is routinely recommended in children initiated on ART, we have very little pharmacokinetic data on ABACAVIR in the small child or in the neonate. There are no dosing instructions for the baby under 3 kilograms. ABACAVIR is therefore not used in neonates or babies under the weight of 3 kilograms. In 2011, the FDA released a statement on LOPINAVIR ritonavir, warning of the risks of prescribing to children under 2 weeks of age. Adverse events included cardiac toxicity and renal failure, and it is thought to be due to the propylene glycol part of the solution. Important to note that premature babies must have reached the corrected age of 2 weeks before you can use Kaletra. So if a baby was born 6 weeks premature, you would have to wait till they are 8 weeks old before Kaletra can be safely used. We do have some studies on the use of Lamivudine in neonates, and PK studies have shown the need for a different dose per weight in infants less than 6 weeks of age. Note that the dose per kilogram for the neonate is half that of the baby older than 4 weeks. Using normal dosing charts could overdose the neonate. There is considerable experience with the use of AZT in the neonatal period, although mostly for the prevention of transmission. Although optimal dosing for treatment is still under review, it is recognized that the standard AZT pediatric dose has a higher risk of anemia in premature infants. Specific dosing for premature neonates are available based on PK studies. Once the baby is 4 to 6 weeks old, they need to be switched to the children's dosing chart to ensure that they are not underdosed. Nevirapine has been used for many years in the prevention of transmission, but the optimal treatment dose for neonates have not yet been established. It is recommended to use the neonatal dosing chart and not the children's chart when setting your dose for nevirapine. There are also concerns about the efficacy of nevirapine in children who have been part of the PMTCT program. Studies have shown that the standard practice of the lead-in dose as used in adults does not seem to be necessary in children under 2 years old in South Africa. So let us look at the included protocol on neonatal management. Please note that this algorithm is only for neonates weighing more than 2.5 kilograms. For neonates less than 2.5 kilograms or for babies that are premature, please contact an experienced pediatrician in your area for advice. Once a baby has tested positive for HIV at birth, we need to make sure to trace and link the mom and the baby to care. And on that first visit, we will take baseline bloods as part of our assessment. A full blood count to assist with the staging, as well as a baseline for AZT initiation, of course our confirmatory PCR, a baseline CD4, and an ALT for the use of nevirapine. We will be prescribing AZT, 3TC, and nevirapine, and note that this is not the same dosing as on the ARV drug dosing chart for children. Please always use the neonatal ARV chart. You can see we are avoiding ABACAVIR and LOPINAVIR ritonavir in neonatal ART regimens. It is essential to have a clear management plan on initiation and to ensure that the child returns to see the same clinician at 1 and 2 weeks after initiation. Do not consider changing treatment until the child is 1 month of age. At 1 month, we can now take our first follow-up bloods, the new baseline bloods for the regimen that we are planning. If the child is now more than 3 kilograms, we can switch the nevirapine to LOPINAVIR ritonavir and the AZT to ABACAVIR. But if the child is still less than 3 kilograms, nevirapine can be switched to Kaletra, but the child must remain on AZT and 3TC. Please note that the dosing on the neonatal dosing chart cannot be used once the child is over 4 weeks of age. And if they are less than 3 kilograms, we're also concerned about why the child is failing to thrive. If at 4 weeks you are unable to change the child to ABACAVIR, 3TC, and LOPINAVIR ritonavir, you have to discuss these children with a pediatrician to look at what your options are. This neonatal chart is also included in your packs and has been developed to ensure that standardized dosing is used for the treatment of neonatal HIV in the first 28 days of life only. Once the child is more than 4 weeks old, you have to move on to the ARV children's dosing chart to ensure that children are not under or overdosed. This chart will prevent any errors when calculating individual doses, but is also important for the proper adjustment of doses with the child gaining in weight. Note that the child only goes up to 6.5 kilograms, as most babies of a month will not be expected to be weighing more than that. Once the baby has been switched to an ABACAVIR, 3TC, and LOPINAVIR ritonavir regimen, the follow-up and monitoring is the same as for children initiated after 6 weeks of age, with the viral load monitoring happening at 6 months on treatment. In summary, it's important to start neonates and small babies on ARVs as soon as possible. But remember that neonatal management is different in neonates than children. Follow a step-by-step approach and discuss with an expert to ensure neonates are managed effectively and with minimum toxicity. Please see the included reference in your pack, and thank you very much to Dr. Harsha Lochin, who did a review of this presentation before publication.